let me briefly inform you and guide you how to navigate the virtual symposium environment. Although I can feel the crowd in the meeting, I don't need to worry about the queue in the registration or information desk. No need for social distancing and carrying a mask. In all meetings, attendees frequently look up the scientific program in order not to miss the presentation of his or her interest. So in this platform, you can simply click on the kiosk screen to view the main program anytime you like. Likewise, you have a question, all you need to do is to visit us from the info desk. Not to mention, you are welcome to send us email at any time you like. This is the invited faculty hall. As you can see from the scientific program, we host numerous internationally well-known speakers in the meeting. In a real meeting, one can hardly find a way to ask questions, but in this platform, it is something that you can easily do without a hassle. Even during the presentations, you can meet the invited faculties in this hall for your questions. Be sure that 19 fertility preservation experts from 8 different countries will be here to share their knowledge and experience with you for 3 days. Here, you can see the door for the conference hall, where main program lectures will be given. We will start live broadcasting on September 11th at 17:30 from conference hall. We have organized a very challenging scientific program, so please don't miss these featured presentations. But for some reason, if you do, all lectures will be recorded and be available for registered participants after the event. Fertility preservation requires multidisciplinary approach that can combine numerous other medical specialties, many experts from different societies. In the affiliated science societies hall, our attendees can find the booths and interact with different affiliated societies, get information, learn and follow their activities. You can also apply for a membership by just several clicks. To access the exhibition area, you will be clicking this door. Exhibition hall will be open 1 day before the Congress starts, so you would have enough time to visit the exhibition area, take a look at the booths and engage with the company representative to get more information regarding their products and services portfolio. We will be doing best for you to enjoy the meeting by keeping you comfortable from wherever you will be joining the meeting. We all look forward to welcome you on Friday, the 11th of September at 17:30 a.m. Central European Time. Thank you and looking forward to welcoming you in our symposium. In the meantime, I wish you good health during this challenging time. Thank you.
Dear guests, welcome to the first online international symposium on fertility preservation. As you all know, fertility preservation is a rapidly growing field of reproductive medicine. Turkish Society of Fertility Preservation Symposium Series aims to gather key clinicians and scientists who are experts in their fields in order to discuss the most relevant topics ranging from cryobiology, ovarian biology to ovarian stimulation protocols and artificial gonads. As the president of the Turkish Society of Fertility Preservation, I would like to welcome you one more time on behalf of myself and our board members. Thank you.
When you're constantly evolving and looking to make the world a better place, you never stop. That's why we'll never stop, building on our history to continue to transform the world of healthcare. We'll never stop saving doctors critical time by turning complex CT and MRI data into 3D images using our healthcare IT systems. which allows surgeons to create simulations before operations ever take place. Working to develop miniature endoscopes to ease patient anxiety during uncomfortable procedures, and point-of-care ultrasound machines that can travel to previously unreachable places. We'll never stop evolving visual imaging technologies engineered to help doctors identify difficult-to-detect diseases earlier. Pioneering the world of pharmaceuticals with advanced drug delivery technologies that use nanoparticles designed to target diseases. Advancing the field of regenerative medicine by applying cutting-edge development and production technologies to provide high-quality iPS cells, which contribute to cell therapy. Pushing the boundaries of biomedicine to help fight diseases like cancer and expand the possibilities of healthcare. And we're entering the fight against aging by using our antioxidant knowledge that prevents film from aging to help advance skincare. Of course, we're just getting started. We'll never stop improving the future by transforming healthcare through advancing the fields of medical prevention, diagnosis, and treatment. And we'll never stop creating value from medical innovation to make the world a stronger, healthier, more livable place. Never stop advancing healthcare. Fujifilm, value from innovation.
Experts from all over the world will be with us to discuss the basics, current state, and innovations of fertility preservation. Please don't miss this outstanding virtual symposium and mark your calendar from 11 to 13 of September. I will be there. Will you?
Mein Name ist Horst Wolf.
My name is Horst Wolf.
Ich bin im Hause Zeiss.
At SYMPOSIUM, I'm responsible for inverted research microscopes in life sciences.
Als Zellbiologe habe ich mir immer
As a cell biologist, I've always wanted a flexible imaging system that would let me perform all different kinds of experiments but still be easy to operate.
ein stabiles System, das vielen
A
unterschiedlichen
stable system that would create optimal conditions for a whole range of samples and deliver reproducible results every time.
mit
Axio Observer is everything I'd hoped for. It lets you combine a wealth of technologies with options to fine-tune it precisely to your experiments.
Sie nutzen die
It
neuesten
uses novel LED illumination for gentle and reproducible imaging.
Wählen Sie aus einem breiten
And you can
Portfolio
choose the perfect
genau
objectives
passenden
and contrasting
Objektive
methods for your
auszuwählen,
applications from the
Ihre Präparate.
wide-ranging Zeiss portfolio. Expand your Axio Observer with AutoCore, and you will always be imaging your samples with the highest resolution and best contrast. Definite Focus 2 focuses your sample automatically and keeps it sharp, even during long-term time-lapse experiments.
Axio Observer ist Ihre
Axio Observer is your stable inverted platform for the challenge of imaging living or fixed specimens.
Weitere Informationen
For further information, visit our website.
As a radiation oncologist, I invite all cancer professionals, including radiation, medical and surgical oncologists, to participate in this symposium, to hear and discuss the timing and current state of art in fertility preservation. Let's focus all together for the best possible functional survival. Looking forward to see you all together in this symposium.
Impril, mitochondrial micronutrients.
Hello, this is Dr. Karlıkaya. Dear guests, due to the time limitation and case-specific problems, specialized stimulation protocols are needed in fertility preservation patients. You can find the answer of your questions by joining to our symposium. You will have a chance to listen to the expert on this field.
Dear colleagues, we are hosting the most experienced physicians to talk about the current practices and future innovations in fertility preservation. Isn't it great? Move to a comfortable chair, grab your coffee and enjoy this wonderful session.
Hi, and welcome to the first international online symposium on expert meeting for the best practice in fertility preservation. This symposium was initially planned to attract colleagues from Turkey and its surrounding countries. Besides its challenging scientific program, we had chosen a very attractive place, Istanbul, the city that combines not only the continents, but cultures that have shaped our civilization today. Now the technology helped us to overcome the negative effects of pandemic and to turn the organization into a virtual meeting. In its current form, the same challenging and attractive scientific content is now embedded with a virtual conference center where you can move around as if you are in a real meeting and join all attractions and events free from time and location-dependent restrictions. We have no doubt that attendees of our symposium will have unique experiences within the virtual symposium environment. Now that you have been through the registration process, let me briefly inform you and guide you how to navigate the virtual symposium environment. Although I can feel the crowd in the meeting, I don't need to worry about the queue in the registration or information desk. No need for social distancing and carrying a mask. In all meetings, attendees frequently look up the scientific program in order not to miss the presentation of his or her interest. So in this platform, you can simply click on the kiosk screen to view the main program anytime you like. Likewise, you have a question, all you need to do is to visit us from the info desk. Not to mention, you are welcome to send us email at any time you like. This is the invited faculty hall. As you can see from the scientific program, we host numerous international well-known speakers in the meeting. In a real meeting, one can hardly find a way to ask questions, but in this platform, it is something that you can easily do without a hassle. Even during the presentations, you can meet the invited faculties in this hall for your questions. Be sure that 19 fertility preservation experts from 8 different countries will be here to share their knowledge and experience with you for 3 days. Here, you can see the door for the conference hall, where main program lectures will be given. We will start live broadcasting on September 11th at 17:30 from conference hall. We have organized a very challenging scientific program, so please don't miss these featured presentations. But for some reason, if you do, all lectures will be recorded and be available for registered participants after the event. Fertility preservation requires multidisciplinary approach that can combine numerous other medical specialties, many experts from different societies. In the affiliated science societies hall, our attendees can find the booths and interact with different affiliated societies, get information, learn and follow their activities. You can also apply for a membership by just several clicks. To access the exhibition area, you will be clicking this door. Exhibition hall will be open 1 day before the Congress starts, so you would have enough time to visit the exhibition area, take a look at the booths and engage with the company representative to get more information regarding their products and services portfolio. We will be doing best for you to enjoy the meeting by keeping you comfortable from wherever you will be joining the meeting. We all look forward to welcome you on Friday, the 11th of September at 17:30 a.m. Central European Time. Thank you and looking forward to welcoming you in our symposium. In the meantime, I wish you good health during this challenging time. Thank you.
Dr. Klaus, please do not share your screen now because I cannot see Dr. Madeline's right now.
Is that
yes.
okay now?
Yes, yes, yes.
Okay.
Okay, okay. Okay, now we are starting. So moderators will now start to talk, and they present Dr. Madeline, and I will send Dr. Madeline to live, okay?
Okay, ça va.
Okay, good luck.
Thank you.
Dr. Klaus, please do not share your screen now because I cannot see Dr. Madeline right now.
Is that
okay now? Yes, yes, yes. Okay, okay.
Welcome and good afternoon. I am Urselik, a radiation oncologist and one of the board members of Turkish Society of Fertility Preservation. We are going to chair this session together with my colleague Kayhan Yakın from American Hospital and Koç University, who is also a board member of Turkish Society of Fertility Preservation. Today we have two main sessions, and in each session three distinguished speakers will be with us. At the end of each session we have 15 minutes for questions and answers, and invited faculty will be available to answer your questions. Even if you do not have enough time to cover all your questions, these questions will be answered afterwards via email. If your question is to a specific invited faculty, we will email your question to him or her. And as the whole session is virtual, there might be a couple of delays and hitches. Please kindly excuse us for any minor technical errors. Our first speaker is Madeline Dolmans, and the topic is ovarian tissue cryopreservation, indications and current status.
I'm sure we all know Dr. Dolmans, but let me introduce her briefly. She is the head of the Gynecology Research Laboratory at the Catholic University of Leuven in Brussels since 2012, and the chief clinician in Saint-Luc University Clinic, Brussels, Belgium. She's one of the top preferred speakers at many international fertility congresses. She is the vice president of the International Society for Fertility Preservation, and she serves on the editorial board of Fertility and Sterility and the Journal of Assisted Reproduction. She is also a reviewer for other international scientific journals. She has published extensively on ovarian tissue cryopreservation, fibroids, and endometriosis. So the stage is yours, Dr. Dolmans.
Thank you, Mr. Chairman, for this nice presentation. First of all, I want to thank Professor Özgür Oktem for inviting me, and also all the organizations, because it's not an easy stuff to prepare. Well, so I will talk today about fertility preservation and ovarian tissue cryopreservation. So my first slide should arrive soon. Voilà, I have nothing to declare, so we can start. Fertility preservation is a new discipline in reproductive medicine, and it started in 1996 for cancer patients. As you can see here on one of these articles published in Fertility Sterility 2018 by the team of Pellicer, since 2004, more and more women are coming to ask for fertility preservation options. And here we see oocyte vitrification and ovarian tissue cryopreservation. Both are increasing every year. This is due, of course, to the success of therapy by the oncologist, but they use chemo and radiotherapy. And we know that one of the side effects of these treatments are premature ovarian failure. So there is a risk of infertility after treatment. And taking back this table from a nice publication already back in 2005 by Hamish Wallace, we can see that in the high-risk group, total body irradiation, pelvic irradiation, and bone marrow transplantation, as well as alkylating agents that are used for Hodgkin's lymphoma, are really at risk of infertility for our patients. If there is a risk of infertility, we want to propose fertility preservation options. Which patient shall we find back in that category? We see here that for the malignant disease, the main indication in our department for ovarian tissue cryopreservation are hematological malignancies, representing 44% of all the patients, with 22% Hodgkin lymphoma, 11% leukemia, and another 11% non-Hodgkin lymphoma. The second most frequent indication to cryopreserve ovarian tissue is breast cancer. And then we have others like sarcomas, cervical cancers, Ewing osteosarcoma, colorectal cancer also. But besides these malignant disease, there are also benign disease that will put these patients at risk. So like oophorectomy can be bilateral for recurrent benign ovarian tumors, but also a risk of premature menopause like we can see in Turner syndrome, or more and more as an indication for fertility preservation, recurrent ovarian endometriosis. Also family history of premature ovarian failure. And then we have the group of bone marrow transplantation for benign disease, like some patients with hematological diseases, hematological diseases or autoimmune disease, lupus. Sometimes they require alkylating agents. But last but not least, there are more and more social reasons. We mean thereby that the patients are postponing their wish to become pregnant. And so that is one of the main causes for the social reason why they come to cryopreserve oocytes or ovarian tissue. Indeed, when we look at the life expectancy, just in Google, in the United States in the 1900s, you see that for female, it was 48 years of age. But if you see how much it is now, 1998, we see that it's almost. So let's go on and talk about how to preserve fertility. I will not talk about the medical therapy with the generate. That is another topic for another day. I will briefly present the oocytes and then we will go on with ovarian tissue. So for the oocytes, just want to stress that if the patient has already received chemotherapy before coming to cryopreserve her oocytes or her embryos, well, question of number, there is no doubt it's a bad thing to do. You see that here we have a little study with 4 patients who received already chemotherapy before coming to IVF, and 1 or 0 embryos could be cryopreserved for these patients. At the contrary, patients who did not receive any chemotherapy, you see there 0, well, we could cryopreserve between 4 and 11 embryos for these patients. So that's a question of number, but there is also a question of quality. You see here a nice study by the team of Merov, and you see here at the x-axis the time in weeks between the cyclophosphamide exposure and the mating. And we can see that, for instance, at 3 weeks after the chemotherapy exposure, when that are born have a 35% malformations. So I think it is an important point to say that in the third point, you see, it is not recommended after chemotherapy is initiated to start to cryopreserve embryos or oocytes. Of course, we need a stimulated cycle, and the harvesting of viable embryos is not a guarantee. Little point, if we have embryos, these are the joint property of a woman and her male partner. That's why nowadays there is more and more oocytes. And we know that oocyte vitrification is an effective and efficient also option for elective fertility preservation. And as you can see here, I just have one slide to stress on the number of oocytes that we should be able to vitrify in order to present to our patients a realistic chance to be pregnant. And this is a paper from the team of Pellicer by Cobo et al. And you see in blue the young patients, so they are less than 35 years of age. And we see that if you are less than 35, these patients will be able, with 8 oocytes, to have a cumulative live birth rate of 40%. Of course, if you would like to have more chance to have your baby and a cumulative live birth rate of 85, you see at the bottom, you need to cryopreserve 15 oocytes. Going back to these 8 oocytes, if we have also in green 8 oocytes, but that the patient is more than 36, well, 36 or more, well, the chances to have her baby will decrease dramatically to 19.9%. So we need to keep in mind that, of course, the younger the patients, the best will be her chances to be pregnant, and that counts also for the cancer patients, where we will freeze these embryos, these oocytes, and also that ovarian tissue. So more recently, this team could compare the outcomes with elective fertility preservation and onco-fertility preservation. And we can see, I choose also 8 to present you today. At the left side, you have the elective fertility preservation, and at the right side, the onco patients, onco-fertility. And with 8 oocytes, they have the same chances to be pregnant. So less than 35, it's a cumulative live birth rate around 32–35%. Of course, the main difference between these two categories of patients is that for the elective fertility preservation, they will be able to undergo maybe several cycles of ovarian stimulation. So they will have more chances to cryopreserve 20–24 oocytes, which will not be the case in cancer patients when we have time to do only 1 cycle usually. So now we will go to the ovarian tissue cryopreservation, which is the only option if the patient is prepubertal or if the patient requires immediate chemotherapy. So what shall we cryopreserve for these patients? Well, we know it's ovarian tissue. Here you see a histological slide about human ovarian tissue, and we can recognize that there are follicles, antral follicles with a lot of liquid inside. These will not resist to the slow freezing cryopreservation procedure, but the ones who will resist to the freezing procedure will be the primordial follicles that are located in the cortex, so only the superficial part of the ovary. And in surgery, there are 2 options to take this tissue. Either we can go for biopsies. In our department, we usually take ovarian biopsies, depending, of course, on the risk of premature ovarian failure. And here you can see the cortex is the only part that we need to cryopreserve, and we do not need to touch to the medulla. So usually this is a procedure that goes very fast, and we try to avoid even to coagulate with the bipolar, the remaining medulla and the remaining ovary. Here you can see an 8-year-old girl by laparoscopy also, but there we need to do oophorectomy. Why? Because in very young girls, the size of the ovaries are very small. You recognize our forceps there, which is 5 millimeters. So these are small ovaries. And of course, a biopsy has no sense there. We need to do oophorectomy. When the patient is cured, well, that's a good point. Maybe she might be menopaused. So in these conditions, these patients will come back to your consultation and ask to have ovarian tissue transplantation back to their body. So these candidates, they usually come back with clinical symptoms of premature ovarian failure, presenting with amenorrhea or severe oligospermiomenorrhea. And of course, there are also biological signs of premature ovarian failure: high FSH, very low AMH, decreased ovarian volume, and antral follicular count nearly 0. So then the way to transplant that tissue, well, we in Brussels, we used to decorticate, so take away the atrophic cortex of these patients and replace it by the frozen taut ovarian tissue. Suture, we don't do that anymore. And usually what we do, we have small pieces, we put them together back on the ovarian tissue reimplantation site, and we cover it with interseed that you see here down. Okay, so if the ovary is present, you can see here on the pictures, we put the little fragments back to the native ovary after decortication of that ovary. And there are other techniques, of course. Here you see in the technique used by the team of Merov, you see also that they take use of that ovary that is still left there in order to put back the strips. And in E, you have the technique in Denmark. And if there is no ovary present, well, there is always a possibility to prepare a peritoneal window with the scissors. A very important point is to check that the vascularization of the implantation site is good, because there you want your little pieces of frozen toe tissue to be revascularized. And I need to stress that point, that when the patient had radiotherapy, which can be often the case because we are treating cancer patients, well, we need to pay attention to have a place to graft not inside this area. Of course, the orthotopic transplantation gives our patients the possibility to have a natural conception, and restoration of fertility has been demonstrated. Probably also the cause of that is that in the peritoneum there is a favorable environment for follicular development, which might not be the case when we have a heterotopic site like in the forearm, for instance. In all cases of ovarian tissue transplantation, there is restoration of endocrine function. So endocrine function, we measure it by FSH and estradiol. And this is already an old publication back to 2011 on the first series of grafted patients. It has not changed. It takes around 4 months between the day of transplantation and the day the patient will have her menstruation back. So how long can an ovarian tissue graft function? Well, it's an important question, I think, indeed, but the answer is it depends on the ovarian reserve that you have frozen and that you can put back to the patients. So, of course, if you cryopreserve tissue in a very young patient, well, you have a good quality tissue with a lot of follicles frozen inside, and when you transplant that tissue back, it will last longer than in the case of a 38-year-old patient. So I would say that in this series of 20 of young patients, less than 22 years, 5-6 years with one ovarian tissue transplantation was easily obtained. You see the case here for 11 years. Well, that is a patient who had 2 transplantations, so she had one, and then the second transplantation was done 5 years after the first one, and that's a way to increase the longevity of the ovarian tissue grafts. So usually when we transplant, we never put back all the frozen tissue, but 1/3 of the tissue. This leaves the patient other chances to have 2 other transplantations. Of live birth has increased steadily each year. You see, starting in 2004, 2005 with these first live births, now we are in 2020 at more than 200 babies born by that technique. So more than 200 live births, all but 2, this is in Japan where they do vitrification, all the other ones were after slow freezing, and it works equally ovarian medulla or peritoneal window. The question, could a combined technique improve the results in terms of live birth? Well, yes, of course, it is always possible in terms of fertility preservation to do both techniques if the patient is an adult patient. In that case, it is important first to cryopreserve tissue and then to vitrify the oocytes. If you do the opposite, probably you will have an ovary with all corpus lutea, and it won't be good quality tissue to freeze. The results of the oocyte vitrification after ovarian tissue biopsy are very good. In fact, the fact of cryopreserving ovarian tissue does not impair the number or the quality of the vitrified oocytes. So now to calculate the success rate, we need a denominator, which means the number of pregnant women on the total number of transplanted women. And that is not easy to obtain worldwide. So that is the reason why in 2015 we started to put these data together from the Brussels team, but also from the team of Denmark with Klaus Andersen, the Spanish team with Pellicer, the Dietrich team for the FERTIProtect, and Rosen for Australia. And there you can see that the percentage of women who conceived, so with the pregnancy, was 29%. I show you now the latest results. Well, in a series, no, that is the series I just presented, sorry. In 2015, 111 cases, pregnancy rate of 29, live birth rate of 23. I wanted to show you these latest results with the team of Dror Merhoff and Sherman Silber, very recently published in Fertility Sterility, with the number of eligible autotransplantation in each center. Taking all these patients together, we can state now that the number of patients who had at least one pregnancy is 50%. So this is really good news for our patients. And also the ones who had at least one live birth is 41.6%. So we can state to our ovarian tissue grafted patients that they have 40% of chance to have their baby. So to conclude, it was time to move on from experimental studies to open applications in 2015. And I think I showed you enough that it is not experimental anymore. And we were happy, all the teams working in the field, to see that the ASRM published in Fertility Sterility last year that it was officially not experimental anymore, the ovarian tissue cryopreservation. I thank you for your attention, and I hope really to see you in live in Brussels in November next year for the next ISFP Congress. Thank you.
Thank you, Professor Thomas, and all the questions at the end of the session. The next topic, ovarian tissue transplantation, clinical results of slow freezing versus vitrification. And the presenter is Klaus Andersen. He is Scientific Director of Laboratory of Reproductive Biology, University Hospital of Copenhagen, Denmark, and Professor of Human Reproductive Physiology within the Faculty of Health and Medical Sciences at the University of Copenhagen. Professor Andersen was a member of the team that introduced IVF in Denmark in the mid-1980s, and during the last 20 years, he has headed a national program of cryopreservation of human ovarian and testicular tissue. He is considered one of the pioneers in this field, and he has published more than 400 scientific papers. He is currently chief editor on the reproduction section in Frontiers in Endocrinology, and the stage is yours, Professor.
Okay, thank you very much. I do hope you hear me now. You hear me now?
Yes.
You hear me now. Excellent. Thank you very much for this kind introduction, and thank you very much for inviting me to present at this very nice conference. I can tell you, I really would have hoped to be present in Istanbul today. Here in Copenhagen, the weather is very chilly. 12, 14 degrees, raining, and I would have loved to be in more nicer climate. Having said that, I would like to start out by showing you this picture, which is a tissue which is just about to be transplanted. This is the vials that the tissue has been kept in during storage, and this is, we always document our cases in this way. So this is one way to start transplantation. When I started to prepare this presentation, I really carefully looked at the title, Ovarian Tissue Transplantation, Clinical Results of Slow Freezing versus Vitrification, and realized that this was actually a pretty difficult title to handle, because this indicates that there's a difference between slow freezing and vitrification. I'm unable to confirm that. And then if it should have any effect on transplantation, I'm also not able to confirm. So I would actually not able to answer the questions I have been posed. This does not mean that I don't have an opinion on how we actually transplant the tissue and what comes out. And I would like to share my thoughts on this. So let's get started. So first of all, I would like to emphasize to you that it is not the freezing process which is the difficult thing that we are facing at this point in time in connection with ovarian tissue freezing and transplantation. This is indeed the transplantation. And we have known this for quite a while now, because this old famous study from the Edinburgh group in sheep very nicely demonstrate that if you have a follicular density in fresh tissue of 192 and you transplant the fresh tissue, you lose 2/3 of the follicles. If you freeze it before you transplant it, you lose another 7%, which basically means that it's not the freezing process, but the transplantation process, which is the difficult part. So the question of slow freezing and vitrification may not be that interesting. And actually, if you look at it, then we have published a paper a few years ago now. Here you have a look of ovarian tissue, the cortical tissue with the ovarian surface epithelium on top of that. And here you see that we actually find the same results as they did in the sheep study in David Baird's group now long ago. This is now human tissue. If you evaluate the survival from a neutral red staining, and this is all the viable follicles you see staining up here red, it's 91% in fresh ovarian tissue. If you look at frozen thawed ovarian cortical tissue, then it is actually 84%. So this means that we only lose 7%. So the freezing process is very effective compared to the transplantation process. And we need to keep that in mind. But let's have a look at the results of vitrification and slow freezing in context of transplantation, just to have as far as I see it. So this is just to state once again, it's not slow freezing and vitrification, which is an important part now. It is the transplantation part. But let's have a look at the vitrified results. So here's a paper from Japan, now Suzuki. This is 2018. In this paper, he reports that there has been 3 live births after ovarian tissue vitrification in Japan. He states that 250 cases of ovarian tissue vitrification for fertility preservation has been performed, while another 1,000 cases of ovarian tissue cryopreservation has been done by slow freezing. But the 3 live births do appear to be the study that they have performed in Japan on in vitro follicle activation. So these are PUI patients who actually do not have a lot of follicles, but still they have been transplanting a lot of women, and they have achieved 3 live births. Exactly the number of women who have been transplanted with tissue, we do not know. But obviously, this is a difficult group. It's difficult to get any efficacy data out of that. It do show vitrification work. It does not show how well it works. So here's another paper from Japan. So now we are back in 2019. And here they state that vitrification was the major protocol used for cryopreservation and was performed in 25 of 27 institutions. And of course, vitrification is then widely performed in Japan. Here they state that 27 institutions, 4 have been performing transplantations, 7 transplantations, 0 pregnancies. So obviously here they do not include those which went into the IVA studies. So this is certainly not very encouraging, but it do not provide any pregnancies here from vitrification. So this is the Japan data. If we look at another center which has used vitrification, this is Sherman Silver, and this is a publication from Sherman in 2018, where he have used vitrification in 4 patients. 2 of these result in babies. So he have 2 babies from vitrification. I would like to notice for you that he have 13 cases in this series. he have 4 vitified, and he actually have 1, 2, 3 which are premature ovarian insufficiency. 7 patients. This is of importance in a little later. So 5 babies perhaps all in all from vitification. So this is of course very difficult to compare to slow freezing, and as Marie-Madeleine showed you, this is the paper where we have seen that there is 130 children born in 2017, and of course there's more. I'm not quite sure about the actual number, but certainly slow freezing do provide pregnancies, and it do provide babies. In Denmark, we have had a total of 26 children, and we have been transplanting a lot of women, more than 100. And you may say, oh, but then your efficacy is not so good. I will like to point out to you that we have transplanted many women who did not want fertility. They just wanted to avoid a menopausal state. And I think we have also specifically actually tested the limits of this procedure because it's free of cost. Any woman in Denmark can have it, and if you come around and you're 36, 37, we will tell the woman that you can have your tissue frozen. Of course, your chances are reduced. So we already know from the women we include that we actually have a reduced chance, but this is our obligation and option to test the limits of this procedure, and therefore we may get somewhat lower pregnancy rates than other people do. But as Marie-Madeleine showed you, let's have a look at this very recent paper where we have the Dwar Myrov group, we have the Marie-Madeleine's group, and we have the Infertility Center with Sherman Silber. And here we have a total of 70 cases. You saw the paper from Sherman Silber earlier, just a few slides ago, where he had 13 cases. In this specific paper, they exclude tissue which have been vitified and which derive in patients with premature ovarian insufficiency. This was 7 cases in the previous study from Sherman, but 11 minus 7 is 4, but here it is 5. So numbers do not add up. So it is not quite sure what we are actually getting at here. But as Marie-Madeleine showed you, it is interesting to notice that these very young women, 26 years of age, and afterwards you actually see that FSH is 19, so it's not all the way down there. But they get, if they only use part of the patients, so they take 10, you get 41. If you include the 70, you get down to 35. And as Marie-Madeleine told you in a lot of previous publications, this is probably what it is, more or less, somewhere in the 30s now. And I think that this is probably where we should leave it at the moment. I think that it's important to stress that there's a lot of factors which are important for the success of transplantation. How much tissue do you transplant? What is the size of the ovarian reserve? As Marie-Madeleine told you, often we have been dividing the tissue into 1, 2, 3 parts so that the patient could have transplantation more than once. If she's older, perhaps she's in her mid-30s, maybe we need to transplant all of the tissue once to get her a fair ovarian reserve that may result in pregnancy. Obviously, the age of the woman at freezing is very important. If you only take young women, then you will get good results. If you allow women to be in their 30s, you may reduce your chances because then the chances of getting pregnant is certainly limited. But it's not 0, and it is a chance for that particular woman. I think that obviously if there's radiation to the pelvis, you have a problem. There may be genetic factors that reduce the number of follicles, then it actually may also be difficult. And I think that the strategy that you use after transplantation for getting pregnancies is also important. Do you, as we have allowed in Denmark, a time period for 1 year for natural fertility, or you do this directly going for IVF? This is a choice as well. And of course, you need to have an expertise in handling low response patients and obstetrical difficult patients. I do see that the chairman is standing there. Is the sound so bad that you don't hear what I'm saying? Okay, nobody says anything. I'll continue. So some women just want menstrual cycles. So it is very difficult to calculate the accurate success of this because it is difficult. Some women may experience relapse during pregnancy. We have seen that. Some women who were pregnant want to get divorced from their partner and had actually an abortion. Cervical cancer patients will need surrogacy if they don't have a uterus. Young girls may want puberty induction but not fertility. Some patients end up having oocyte donation despite some tissue remaining in storage. And we have had pregnant women more than 5 years after the tissue was transplanted. So I would like to urge, I think it's impossible to compare the success rate of grafting ovarian tissue with IVF treatment for many years. I think we can confidently say that there is pregnancies. It do come up to somewhere in the 30s. Maybe it isn't even go higher, but a precise pregnancy rate we cannot come up with. If we transplant it, as Marie-Madeleine showed you, there's 3 options. We put it directly into the ovary, to a subperitoneal pocket, or to the anterior abdominal wall, and equally, the tissue will work equally well, irrespective of where you transplant it. That's important to understand. So it do work very well when you transplant it. As Marie-Madeleine told you, there's advantages and disadvantages of using a transplantation site outside of the remaining ovary or in the remaining ovary. Obviously, here's you can replace a higher number of ovarian pieces of tissue. And I tell you, we often actually use a combined approach because the remaining ovary is postmenopausal and can only contain 5 or 6 pieces of cortical tissue. And then we put the rest outside of the ovary. And you can see here there's more disadvantages with each of these 2 approaches, but often they are combined. If we look at the sawing process, it's pretty straightforward. You put it in 3 consecutive different solutions, and you lower the concentrations of ethylene glycol and sucrose, and then you have it in PBS, and then you transplant it, and here's the tissue ready for transplantation. A heterotrophic site would mean that we do it laparoscopically. Here has the tissue. We just put it into a peritoneal pocket one by one, and we have it here, the tissue, and then it's moved into the ovary through the port here. Pretty straightforward. Here is ovarian tissue. We have just transplanted new tissue here. This is ovarian tissue in a subperitoneal pocket from a previous transplantation. You can see 2 follicles being developed here, and it do work very nicely at a subperitoneal pocket. If we do it in the ovary, this is the orthotopic transplantation in its purest form. Transplant each individual piece of cortex here, stitch it together, and just put it back to the abdomen. This is a mini laparotomy. We are now also using elongated strips. This is basically the Dormairov technique as it's been presented, where we have pieces of ovarian tissue which may be 2 centimeters long, and then we just drag it underneath the cortical surface of the ovary, and then you leave it there. This is just to show you a small video performed by Margit Duerholm and Erik Ernst in University Hospital of Aarhus, and they do, let's see if this will work. It does. So here's the laparoscopy, here's the postmenopausal ovary, the uterus, and here we have prepared a pocket, subperitoneal pocket, where we are putting in the pieces of tissue one by one, and I will just advance this so we can see here more pieces are put in there one by one, slowly making sure that they are flat against the underlying surface so that they have a better chance to be revascularized. You can see here the last pieces are being put in, and then you can see the pieces of tissue here in the pocket. Then you stitch this together. Again, just showing you how they look sitting in there. and then it's stitched together. And there you can see the pieces of tissue, and then you don't do anything else and leave it. And then, as Marie-Madeleine told you, 3-4 months later, the tissue will start to work. So I think that if we are looking more widely at how this is now performed and what people are currently trying to do for improving the transplantation efficacy internationally, there's a lot of studies now going on to reduce reactive oxygen species. N-acetylcysteine, NAC, is being used, vitamin E, melatonin. There's some positive data on that, not really changing the outlook, but perhaps we may get something here. Of course, the prevention of hypoxia by upregulation of angiogenesis is obvious, and there's different approaches to that. You can either try to put in different growth factors, VEGF, you can put in EPO, which also act to promote angiogenesis. So there's various different ways to enhance angiogenesis. You may put in stem cells, mesenchymal stem cells, adipose stem cells, but this is sort of a rather loose term that if you put in the stem cells, you hope that they secrete growth factors, which will then enable angiogenesis, which is sort of not a very solid mechanism of action. But there's also positive results here. Sphingosine 1-phosphate, SP1, has been reported to enhance angiogenesis and survival of primordial follicles. We have been looking at that. We are unable to repeat that. But there's a lot of studies going on, and this is the way we need to go forward. We need to improve revascularization and avoid hypoxia of the transplanted tissue as much as possible. I think that we, at least in Denmark, have had 3 very simple things that we need to consider before we transplant tissue, which we need to understand. And one of them is that make sure that the partner doesn't have a compromised sperm sample. At least then you have to take them immediately for ICSI, but you need to evaluate the male partner too. And then the woman, if she is smoking, needs to abstain from cigarette smoking at least 2 weeks prior to transplantation. You very well know that if you have smoked, transplantation is for skin and other organs is not a good thing. And then you have to make sure that the cortical side fades upwards. So I think that what we need to focus on research-wise now is to avoid hypoxia and reactive oxygen species after transplantation. This is the important part in order for us to increase success. So let me just here finishing off, looking at some data that we published a few years ago on the transplantation reports as reported in peer-reviewed papers as of 2018. And here you can see that a lot of different countries are listed, 360 cases of transplantations in 318 women. You will actually notice that Japan, who at that time only had 3 vitified pregnancies in these POI IVA patients, are not included. But otherwise, there's a lot of countries where you have this coming out. And I think that the really important message from this study is that there is no relapses reported in connection with these transplantations. If you look at it, then you can see the different diagnoses very closely resemble the frequencies by which the ovarian tissue is actually frozen. So hematological malignancies 35, gynecological malignancies 19. This is breast cancer. This is colorectal cancer. And so this is non-malignant diseases. Here you have Ewing sarcoma, and here you have other malignancies. So this very nicely demonstrates that there's a huge array of diagnoses in which ovarian tissue have been shown to work. This is just the actual numbers for gynecological malignancies, breast cancer, and so on. If you split it up, you can see there's a few ovarian cancer. This is pretty brave. No relapse reported from this yet. Cervical cancer 14. I think it's important to notice that morbus Hodgkin is probably the best tested indication and there's no reports of relapse from morbus Hodgkin. So it do not appear that morbus Hodgkin related malignant cells are being preserved in the ovarian tissue when it's transplanted. Important also to notice that if you look at the way that women who have had frozen thawed ovarian tissue transplanted, it is the methods of conception is natural in more than half of them. So they do obtain their natural pregnancy in most instances, which is very nice for these women. They have been through a lot of different disease, and actually they are happy to be able to just do something naturally. And this is an old study of ours from 2015, where we look back and you can see that the tissue, this is years that the tissue have worked. We actually do see that the tissue work for considerable periods of time. And I think that this is very important. Also, if we look at other uses of ovarian tissue as postponing menopause or using it for endocrine purposes, that there is actually, for many of these, quite a substantial number of years where the tissue works. I think it's fair to mention this study from Beckham in Germany, where they looked at surgical complications in connection with this, where they looked at transplantation of 71, and they had 1,300 ovarian tissue freezing laparoscopies, 2 complications, small, not very severe in removal, and 1 during transplantation. So this is a pretty safe option. If we ever should get in the situation that we may end up by having transplanted the wrong tissue to the wrong patient, then I think that contrary to oocyte and embryos, it will be rejected by the immune system and cause no harm. So this is also, of course, this shouldn't happen, but it's nice to understand that this will probably not cause anything. So in conclusion, I would like to say that transplantation of frozen thawed ovarian tissue effectively restores ovarian function and fertility. Okay, so I'm shut off now. So thank you very much for listening to me. I will stop now. All right.
Excellent talk. So the next topic is now will be presented by Dr. John Mero, and the topic is the effects of chemotherapy and radiation on gametes, mechanisms and protection. Let me introduce Dr. Mero briefly. Professor George Mero is the chair of Maurice Kahn Center for Fertility Preservation Division of Obstetrics and Gynecology at Shiva Medical Center, Tel Shomer, Israel. He's a professor at the Sackler Faculty of Medicine, Tel Aviv University, Israel. He was the former president of International Society of Fertility Preservation. Professor Mero's basic and clinical research is focused on the effects of chemotherapy on reproduction and modalities for fertility preservation, especially on ovarian tissue harvesting for cryopreservation. First case of IVF pregnancy and delivery from transplantation of cryothawed ovarian tissue in the New England Journal of Medicine. Professor Mero's laboratory team published a pioneer study in the Science Journal, providing a new understanding of the burnout mechanisms involved in chemotherapy-induced ovarian damage and testing a novel fertility-protecting agent. We are happy to have you, Dr. Mero. The microphone is yours.
Hello, can you hear me?
Yes, doctor.
Okay. Do you see my presentation?
Yes, stage is yours.
Okay. So thank you very much for inviting me for this interesting session, meeting. Although we are all at home and I like Istanbul very much, so I'll be very happy to attend physically next time. So my topic will be on the effects of chemotherapy on gametes and mechanism and protection. This is the fact that we all know, that after administering chemotherapy, when the patient goes into ovarian failure, this is the end result that you see, atrophic ovary with no follicles, and of course the patient suffers from infertility and premature ovarian failure. There are many publications describing the effect of cytotoxic drugs on the ovary, and you can see here some of them, and they are coming from rodent studies, human ex vivo study, xenograft in vitro and in vivo studies, and you can see different effect of chemotherapy on oocytes, on growing follicles, and on dormant follicle. And I will try to lead you as I understand the topic now, and actually all the time there are changes that are coming from a different center all over the world, and which is a very interesting topic. And the reason for this is that first, it's interesting to know what is the effect of chemotherapy on the reproduction and gametes, but also in order to find some kind of medication that might help to prevent this toxic event, we must understand how it works. So if we want to summarize, chemotherapy acts on the primordial follicles, it acts on the growing follicles, and there is the stromal effect that causes fibrosis and causes effect on the blood vessels and apoptosis in the stroma of the ovary. So there has been quite a lot of publications about options to prevent such a damage, and I just show you so many medications and formulas have been used, but in general you have the GnRH analog with ovarian hormonal suppression. We have, and all the rest are preclinical and basic science investigation. We have a medication that act on apoptotic pathway, that if you want to prevent the damage to the gametes and the ovarian reserve, there have been publications using anti-apoptotic medications. There have been formulas and medication that have been used that act on follicle activation pathways, and they have also medication that used to inhibit vascularization, interference with transfer of the medication, and many other indications as well. So let's go to the basic and look. This is the apoptotic pathways in the ovary, and if we can block, as I said, those apoptotic pathways, can we block follicle loss? And also we need to know we should not decrease the effectiveness of chemotherapy, because the main reason we give this chemotherapy is to kill the cancer cells, and if we prevent the apoptotic pathway, maybe we'll decrease the efficacy of these chemotherapy agents. So there have been quite a lot of in vivo animal studies that show that anti-apoptotic that show that you cannot see apoptosis in primordial follicles following chemotherapy. One of our publications looked at alkylating agents in the dose that is used in clinical setting, and what we have observed is that you can see a lot of apoptosis in growing follicles, as you can see from the left side here. And growing follicles, of course, we saw a lot of apoptotic, but on primordial follicles, we could not demonstrate, and this was the doses that are very high doses, but that are used on clinical setting. However, when you look on other medication, and this publication from the group of Richard Anderson, you see that when you give alkylating agent or doxorubicin, when you look at the follicles, they don't look healthy. but this was not in vivo. These are ex vivo experiment when the ovary was in 6 days in culture and the chemotherapy was given in vitro. So, but nevertheless, they saw, you can see here the effect on the granulosa cells on the oocyte itself. Recent publication looked on apoptosis in vivo, and you can see here a publication by Gonfloni, and you can see here that indeed they saw signs of apoptosis in the primordial follicle after chemotherapy. And this is human ovaries that was ovarian xenograft following chemotherapy, and you can see here also sign of chemotherapy. So there have been some studies showing apoptosis, direct damage to the follicles and direct damage to small follicles by chemotherapy, by xenograft, and also in vivo. There have not been any study in vivo showing primordial follicle damage in human ovaries. You can see here also a study by Neigen in human reproduction, and also here they looked at a tunnel, and you can see here positive tunnel staining showing death, direct death of small follicles, and also damage to the DNA after staining by gamma H2AX. So the other mechanism that had been proposed to cause damage to the follicles by chemotherapy is what we called the burnout effect. In our publication already a few years ago, we showed that chemotherapy alkylating agent induced recruitment and growth of primordial follicles, as you can see by Ki67 staining. And you can see here the growth of adult mice and also 5-day mice after exposure to chemotherapy compared with controls. And the mechanism that we proposed is that there is death of a growing follicle and there is the loss of suppression of by chemotherapy, and this induces growth of a follicle, and by this you lose them after administration of cyclophosphamide. And this was the PI3K pathway that has been shown to be activated after administration of chemotherapy. Since our publication, you can see here, many other publications confirmed our results showing follicle activation post-administration of alkylating agents and chemotherapy. So does it happen in humans? And this is our recent study. And we took patients that underwent ovarian tissue cryopreservation after being exposed to chemotherapy. And we had 3 groups of controls, patients that were treated with alkylating agents prior to chemotherapy, and patients that had been treated with non-alkylating agents. And the time range was short, which is include the time that takes for primordial follicle to mature. Here was 3.4 and here was 4.3 months. And what we can see here, that apoptosis with staining with caspase-3 in primordial follicle we have not seen whatsoever. Here's the untreated and here's the alkylating agent, and there was no difference. We didn't see more apoptosis after exposure to alkylating agents. But growing follicles, of course, they were highly exposed and developed, was positively stained for caspase, and this was highly significant. And when we counted the follicles, you can see here reduction in primordial follicle number after alkylating agents, not significantly after non-alkylating agents. Growing follicle increased, but one of the most important thing was that was a time relationship. The shorter the time after exposure to chemotherapy, we had more growing follicles in tissue, and this reduced to normal after 6 months, when the interval between chemotherapy and the tissue retrieval was 6 months. So when the time was very short, we had a lot of growing follicles, although we know that growing follicles are immediately destroyed by chemotherapy. And this, of course, influenced also the ratio. When we looked on the blood vessels, what we saw, and this is against our publication from 2007, we saw, yes, there is a fibrosis in the tissue after exposure to chemotherapy. And yes, there is new vascularization after exposure to chemotherapy, but this happens long after we already lost the follicles. So this is not the cause, might be the result. So the conclusion of our human in vivo study, it demonstrates for the first time that alkylating agents activate the growth and increase of primordial follicle pool in human ovaries in vivo, and human results combined with animal studies support the hypothesis that chemotherapy induces burnout effect and point to an optional target for medication that might reduce chemotherapy sterilizing effect. Here's another publication in reproduction by Lopez and the group of Richard Anderson, and you can see here, after a short time, the effect of chemotherapy on the stroma. And yes, there is a lot of death of follicles and not signs of activation in the stroma. So here you can see a lot of apoptosis and not increased activation. So when we looked on the mechanism of activation in the ovary, there are several mechanisms. We looked into two. One is the PI3K pathway, and the other one is the anti-Müllerian hormone. So yes, publication has come that by a co-administration of chemotherapy with PI3K inhibitors prevented loss of follicles after chemotherapy. And this was the work of Goldman that was published in 2017 in PNAS. Not only follicles survive, but also the mean litter size was increased compared to chemotherapy. And this is a work of our team, and you can see here that by administration of temsirolimus, which is a PI3K inhibitor, you can see here the ratio of, you can see here signs of proliferation, and this is the blue is no proliferation, and this is partial proliferation and strong proliferation. So with temsirolimus, of course, you have reduced proliferation, and with cyclophosphamide, you have significant increased proliferation. But when you combine the PI3K inhibitor plus cyclophosphamide, you again get the quiescence effect, and most of the follicles are in a not proliferative state. And when you administer these agents together with chemotherapy, and this is our publication using the AS101, again, you can see that with chemotherapy, the ovaries become small, you have less follicles and less ovulations, as can seen by corpus luteal. But when you combine the cyclophosphamide with the AS101, you can get again very similar to the control. And also with reproduction, you have more with the protective agent, you have more pups and more mice that conceive. What about the anti-Müllerian hormone? Again, a mechanism of prevention of follicle activation. We measured AMH levels immediately, very shortly after administration of chemotherapy, and you can see here this drop, and this probably occurs by the death of those growing follicles, and afterwards we had this overshoot of increased AMH production. And what we did, we administered AMH, which was stained specifically, and we could show that it reaches the ovary, and we wanted to see if by preventing activation we will rescue the ovary and have more follicles. So there was a publication also in the PNAS by Kano Group and Donahoe, and they showed that if you give AMH together with platinum derivatives, you really prevent follicle loss and rescue fertility. And here is our publication that we use external AMH, and we stained it together with biotin. And where you see here the yellow, it means that our AMH reached the ovary, and also it had an effect. And by measurement of the SMAD, by measurement of the SMAD in the cells. So our results also show that co-administration of AMH together with alkylating agents prevented follicle activation and kept the population of follicles more follicles survived the chemotherapy. And when we looked on reproduction, we have pregnancy rate increased and mean litter size increased as well. So by giving AMH together with chemotherapy, we can reduce follicle loss and increase fertility. This is one of the important things to show that the medication that you provide will not reduce the effect of chemotherapy on the cancer. So we used two models, one of human breast cancer cell line and the other one is of leukemia. And in both cases, we showed that co-administration of AMH did not reduce the effectiveness of chemotherapy on the breast cancer cell line and on the leukemic cells. So we have the two major points of effects of chemotherapy. One is the apoptosis, one is the prevention of the activation pathways. But this is a publication from Belushi that showed that maybe both things are acting together. So here is when you give cyclophosphamide, you get follicle activation that eventually results in apoptosis, or you can have direct effect that causes DNA damage, as we saw before with gamma H2AX, that actually will lead again to apoptosis. These things are currently under investigation and more studies are needed. So to conclude, chemotherapy effects have several targets. Primordial follicles are activated post-alkylating agents administration. Follicle activation has been shown in vivo in human ovaries. PI3K inhibitors prevent follicle activation, preserve follicle reservoir, and rescue fertility. AMH prevents follicle activation, preserve follicle reservoir, and rescue fertility. PI3K inhibitors and AMH are not anti-apoptotic, but prevent chemotherapy-induced follicle loss. But as I said before, we need more study to further clarify ovarian toxicity caused by chemotherapy. Thank you very much for your attention.
Thank you very much, Professor Meiro. It was a great presentation. For questions and answers, I'd like to give some information regarding the symposium content. Registered participants will have access to symposium content for a week after the symposium, and we have received many questions. Would you go ahead and ask?
Yes, I regret to say that due to time constraints, we will not be able to forward all the questions to the presenters. So in the principle of first come, first serve, I will forward the first arriving question to Dr. Dolmans. The question is, How are you feeling about the safety of ovarian tissue freezing in cancers with high risk of ovarian infiltration, such as leukemia or other cancers?
Okay, so that's indeed a good question. There is a risk, as we demonstrated with the xenografting study, with acute leukemia specifically. And on the other hand, the publication of Dromerov showed that it is still possible to transplant. So what's the difference between these two things? It's not contradictory. The idea is that there is a risk and we need to be careful. So before transplantation, we should double check if and try to evaluate that risk. So what we are doing is, of course, histology, immunohistochemistry with specific markers, but also, and that is mandatory for these at-risk cancers, molecular biology markers. So you need to know what is the molecular marker of the leukemia specifically, because each leukemia has a different molecular marker. And so you need to perform molecular biology on a sample of frozen toe tissue. And the last test is the xenotransplantation for long-term into SCID mice. I think if you have done all this, you can be sure that in the tested fragment, there is no leukemia. And then it's another little risk to extrapolate that all the other tissue that is frozen has the same issue.
Thank you indeed. And the next question is going to Dr. Anderson. Do you think it would be beneficial to use in vitro activation before transplantation of ovarian tissue, especially in cases with premature ovarian insufficiency?
This is indeed also a very interesting question. And obviously, if we are able to do in vitro follicle activation, this would be a splendid opportunity. I just don't think that we have been able to do what they have done in Japan. We have done a huge study, and they have done a huge study in EV, and we are not able to recapitulate what they have been doing in Japan. So at least in our mind, there is we need to study this further in order to understand how the activation of human primordial follicles is actually regulated. But if we do get to that understanding, it is indeed a good idea. We don't hear you. Don't hear you. No, we don't hear you. Yeah.
I will repeat the question. That question is forwarded to Dr. Dolmans. What is your opinion on social ovarian tissue cryopreservation? Have you ever cryopreserved ovarian tissue for social reasons? If you did, at what age and to whom do you recommend freezing ovarian tissue?
Thank you for the question. So far at the Catholic University, we did not freeze ovarian tissue for social reasons, but the demand is increasing, I think. And there is a rule for all fertility preservation. It is shown by the Cobo et al. Articles. Really 35 years is a good limit. The problem is that the patients who want to cryopreserve the tissue or the fertility potential, they often come between 35 and 39 because they start to realize that it is time. So I know that for oocyte, they easily take until 38. I hope this answers the question.
Yeah, thank you very much. This is enough and great. So the last question, this might go to any of you, but let's ask this question to Dr. Meiro. What's your approach to reduce ischemic damage in transplanted tissue in your practice?
Well, the way that we do it is the technical way of surgery, that we put the ovarian tissue like a sandwich, as you saw by Klaus that showed it before, that we use the atrophic tissue and we make a tunnel in the ovary to put the ovarian tissue, so we get the maximal proximity. This is the one way. The other thing was the question of the size of the tissue that you freeze or transplant. And actually, in our recent publication, we didn't see any difference if you had very small fragments, medium size or larger size of fragments. It didn't make any difference. Perhaps with larger study, we will see, but at this point, I cannot say that smaller fragments are more effective than larger fragments.
Thank you. Here's another question to Dr. Meiro. GnRH analogs. GnRH analog suppression to preserve ovarian tissue damage.
Well, many publications go in favor of its efficacy, though there are quite equal publications that say it is not efficient. As a clinician, I have to say that there are quite a lot of benefits to give GnRH analog to cancer patients when they are treated with chemotherapy. It's very effective contraceptive. It's very effective to prevent bleeding when the patient is very highly thrombocytopenic. So the way what we tell our patients is maybe it will help, but there are other benefits. So in general, I think that many of our patients will receive GnRH analog.
Thank you, and thank you to all the presenters, all the audience. The time is running so quickly. We have other questions, but please forgive us for closing this session. We will forward the questions to the addressed names through emails, and you will receive the answers in your own email boxes. Thank you. See you in the next session.
Thank you.
Thank you very much.
Welcome again. The first session was great, and hopefully this will continue as the first one. Our session is starting with Professor Tornaye, and the topic is sperm and testicular tissue freezing in male cancer patients. Dr. Herman Tornaye is full professor and chairman of the Department of Gynecological Fertility in the University Hospital of the Dutch-speaking Brussels Free University, and in 2000 he started the research group BITE, Biology of the Testis, focusing on the reproductive potential of testicular stem cells. He has authored over 400 peer-reviewed papers. And at the medical faculty, he currently teaches developmental biology and embryology and reproductive medicine. He is coordinator of the international training centers of the European Board and College for Obstetrics and Gynecology and the European Academy for Andrology, both associated to his university hospital. And the stage is yours, Professor Tornaye.
Thank you, Mr. Chairman. So good evening, dear colleagues and friends in Turkey and other countries probably. So the first slide, I don't have any conflict of interest with what I will present in the presentation tonight. And it will be merely a more clinical presentation. And I would invite you, if you want to go more the scientific way, to listen tomorrow to one of my co-workers, Joni Baert, and he will present a very nice topic on the artificial testis and the development of the artificial testis with stem cells. Okay, so this is what we are going through. So first, maybe in a few words, what we should all know, I think. We know that chemotherapy nowadays is a very effective treatment also for male cancers and especially for men in their reproductive age. The downside, of course, is that there are a lot of side effects that we put together under the terminology gonadotoxicity. Mainly, there is a loss of the spermatogenic stem cells and all the proliferative stem cells, of course. Luckily, Sertoli cells and Leydig cells, they are both quite resistant. They are not in a mitotic phase. And so the risk for hypogonadism is quite low. Nevertheless, it seems that, of course, depending on which dosage, which type of chemotherapy, also maybe the age of the patient, that of course, because of the loss of the stem cells in the testis, there is indeed an increased risk for oligozoospermia or even azoospermia. But also, and this is something that we often forget apparently, there is also an increased risk for erectile dysfunction. Nevertheless, that Leydig cells are resistant, apparently there is a 2 to 3 times more risk to end up after chemotherapy with an erectile dysfunction, which also, of course, may be a problem for fertility. If you want to know everything that is nowadays, let's say, routine for preservation, I will not go into detail. There are plenty of review papers, and myself with Gert Tolle and Chris Barrett, we published, I think, a still good actual review in The Lancet a few years ago, which lists up everything you should know, I think. So I would prefer to focus on more the controversial things in the clinic about the banking of sperm especially, but also banking of stem cells maybe. The first controversy that we always encounter is the discussion we have with the oncologist, with other specialists treating the patient with cancer. They don't refer a lot of patients, and one of the reasons is that they think it's not worth it to send their patients. The reasons are always the same. They think that quality of life is inferior to survival. They think, or they estimate, that the patient is too ill to delay any treatment, which is often a very strange statement, because sometimes they take 2-3 weeks to make a diagnosis, and then once the diagnosis is made, of course, treatment should follow directly. No 24 hours time even to do something. They think that indeed there is a lot of time lost when you postpone chemotherapy to freeze something. And another important reason, not in my country, because I live in a small country, but especially in bigger countries, like maybe Turkey also, is the problem of banking facilities. They are not always nearby, and sometimes patients indeed need to travel for a couple of hundred of kilometers to reach a bank. In many countries, banking is also expensive. In my country, Belgium, there is a reimbursement for that, so it's not expensive. But in many countries, of course, this is not the case, and so you have to pay something, and of course, you're facing already a lot of costs for your cancer treatment. And then also there is a general assumption that the quality of the material that you can bank, sperm, is compromised, and so it's already compromised when you send the patient, when you refer the patients for banking, but it will also be more or even more compromised when you thaw the material to use for insemination, IVF, ICSI, etc. And then an important issue is also that a lot of studies, and I will come to that, show that the material that is in the banks is hardly used by patients. So why would you do it if it's hardly used? And then a very important one, especially the last few decades, is that, of course, there always are new chemotherapy protocols that find their way to the clinics, and many of these protocols are so-called fertility-friendly protocols with a low risk for subfertility or infertility. Of course, we know, we are in the field of reproduction, we know that nowadays you don't need to send your patients several times. You can really do it in one stop. So in fact, one single sample for sperm banking can do the job, because indeed, thanks to ICSI, one sample, you can do several trials with that single sample you have in your bank. Now, the problem is that we know it, but a lot of the colleagues that should refer their patients, they still don't know it. So here you see a study, it's already old, but it's about more than 10 years after ICSI was introduced, and you see in Ireland, oncologists were asked whether they ever heard about ICSI, and only half of them, they know about ICSI. So half of them, they know about ICSI. So they are not aware of the technology we have in our clinics. They also are unaware of the fact that ICSI is a technique that is really focusing on patients with very low sperm quality. So they're really unaware of the fact that this is a really good tool to cope with even compromised sperm. But if you see, this is a more recent one, so 20 years after the introduction of ICSI, this is a study from Saudi Arabia. So it says Arabic communities, but it's a Saudi Arabian study. And you see, again, 50% of the colleagues, the oncologists, have ever heard of ICSI. And so the referral in that study was only 20%. And then you can imagine whether these colleagues know about testicular biopsy and microtesis, so probably they really don't know, and they don't have a clue what we can do for their patients. On the other hand, and we are all, I think, part of it, at least I'm part of that lobby, we think, or at least I think, that every male cancer patient must bank something, because the reason why is simple. You don't know whether that patient, if, for example, a chemotherapy regimen says that there is a 90% chance that fertility will be still there after the chemotherapy, maybe your patient will be part of the 10% that becomes azoospermic or severely oligospermic. Another important issue is that a lot of times we see patients that indeed started with a so-called fertility-friendly protocol, but because the cancer is not well treated, at a certain point, the oncologist takes the decision to go for another treatment, and then he will send the patients. But of course, in that phase, your patient is in the phase of being azoospermic, of course, because of the fertility-friendly protocol. Spermatogenesis will start up, but in that phase, the shifting phase, there will be azoospermia, and we cannot bank anything. And then also, of course, oligozoospermia doesn't mean that there is fertility. Many of these studies, they say, look, there were still some sperm around, but our waiting rooms are full of men with some sperm around, and they are still in the fertility clinic. Another reason why you can prefer to bank is that indeed there can be some effects, epigenetic or genetic effects of chemotherapy and even radiotherapy on the spermatogenesis. And so by freezing before these treatments, you may circumvent that problem. Also, it's good to know that it's not only sperm semen that we can freeze, but in men who seem to be azoospermic, for example, men with testicle cancer, there is always a possibility to recover sperm, at least in about half of them, by a so-called oncothesis procedure, And what we know is that indeed freezing, banking will increase the chance for having a genetic own child. And for example, this is a study by the hematologist, European hematologist group, and they were looking to 902 patients with Hodgkin lymphoma. And in fact, what the conclusion is that the odds to have a child is 2. So in fact, you double your chance indeed when you cryopreserve. So you can say it's not worth it, but at least studies like this, and there are a little bit more than that, but this is a big one. They show indeed that you increase your risk, your chance, let's say, by 2, which is substantial, I would say. Of course, these are the typical controversies that are going on, unfortunately, for already decades, and they are still under debate all the time. There are also some issues that are not resolved within our field by ourselves. One typical one is I get quite a lot of patients referred from Holland, because in Holland, when a patient has cancer, they don't want to freeze anything anymore. Or sometimes patients are referred that already started their chemotherapy. And so there is a bit of discussion about whether this is a good thing to do. In Brussels, we will freeze during chemotherapy. You see here a very old case report that raised a lot of discussion about the patients undergoing chemotherapy, but in the meantime banking, and you see that it takes about 2 months before he becomes azoospermic. So in Brussels we do the same, although we label, of course, the specimens, those who were before, if they are available, of course, and those banked during chemotherapy. And you see there was a lot of controversy, a lot of reply to the authors, etc., mainly referring to studies in rodents, in mice and rats, showing that banking during chemotherapy probably is not a good idea. On the other hand, what we do have is very, very few data, unfortunately, in the human, and they show that before chemotherapy, during chemotherapy, and after chemotherapy, there is an increased risk for aneuploidy in the sperm, but as you can see, for some chromosomes, it's not that high. For others, it's higher. There is also, but again, very few studies that look to DNA damage. And here you can see that it depends from patient to patient. This is proven controls. These are the sperm donors. And this is a study from Holland, from Rotterdam. And as you can see, the DNA damage, depending on which type of cancer, this is testicle cancer, Hodgkin lymphoma, non-Hodgkin lymphoma. And you see that indeed it's in the same range as the normals, but you see there are outliers. And the strange thing is, in the non-Hodgkin, even before treatment, before chemotherapy, the fragmentation rate was already very high. So we need definitely more data about this, because it remains very controversial even within the field. For the aneuploidy, of course, we do have, I think, a solution, because aneuploidy nowadays, there are several platforms available for aneuploidy screening on our embryos, so that I think should not be really a problem anymore nowadays. Of course, the epigenetic and the mutation load that chemotherapy may give, that's another question. On the other hand, there are some studies, and some of them are very big, like this study from Denmark and Sweden. As you can see, they were looking to men who fathered a child or children, and you see it's more than 8,600 men. And indeed, there was an increased risk for congenital malformations in these men. Some were, of course, conceiving during chemotherapy, some were conceiving after chemotherapy, majority. But although this increase is statistically significant, from a clinical viewpoint, it is a moderate increase, I would say, and I'm not sure whether for a patient from the patient viewpoint, this is really, the increase would be substantially enough to say, look, refrain from getting pregnant after chemotherapy or maybe even during. On the other hand, the typical cancer where you expect that there would be a lot of problems is testicular cancer, because the chemotherapy is really focusing on the testicular stem cells. Testicular cancer is a cancer of testicular stem cells. So you would argue that there the problems are really high, but there are very old studies, as you can see, limited numbers, but you see the conclusion is always the same in the human. The number of healthy children conceived during chemotherapy for testicular cancer was remarkably okay. Here you see again a study from Scandinavia with more than 4,000 children. And again, you see there was a modest increase in malformations, but in fact, if you looked for other factors, the truth was that there was no additional increased risk. So it seems to be quite okay, not in rodents, but in humans, it looks okay. Then I would like to come back to the utilization rate that people always argue, look, only few patients will use it. It costs a lot of effort for the cancer patients to bank something. And you see, this is a systematic review from Italian colleagues, and almost 12,000 patients included. And you see, of course, there is a dropout. There is people die. People got pregnant or say, look, we don't want children. So there is about, as you can see, almost 1 out of 3 samples disappear from the bank. But in the end, based on a few studies, you see that about 8% of men actually will, in the end, use the sperm, which is not a lot. That's true. 8% is low. But those who use the sperm, half of them will indeed get a child. Now, is 8% high or low? Well, that's up to you. But the truth is that all of you listening to me or watching me, you all have a fire insurance, I think. And we don't use 8% of the fire insurances. So we spend a lot of money paying for fire insurances, while apparently we have some hesitation to pay for an insurance for banking sperm. So I think that this is what patients should be told. This is a sort of insurance, and even if the utilization rate is only 8%, I think it's worth it. The problem of distance, the problem of access to freezing is, of course, an important one. And there also we have a problem, I think, in the field, because you see, there are very old studies from the 50s in the animal world, and even the recent ones. This is just published a couple of months ago, and it looks to freezing sperm in low resource settings. In the animal world, you can imagine that. And they use simple methods like this one, and this is called a Mr. Frosty. And a Mr. Frosty is just a box that you fill with isopropyl alcohol, and then you put it in the -80 freezer overnight, and your sample is frozen. You can keep it for weeks, even months, and then eventually you can put it in a bank with liquid nitrogen later on. But this is something that every hospital can do, if you like. Okay, that brings us to something else. Where is the age limit? Because so far sperm from an ejaculate, that's easy. We know that there are several programs in Europe where indeed people try to convince parents and boys to freeze as early as possible, and this is possible from the age of 13 to 14 years. But of course, you need a dedicated program. In case it's still a taboo for the boy or for the parents, and the best thing that you separate them and that you talk to the parents apart, and also to the boy. Boys, they know nowadays with the internet very early what masturbation is, how they can do it, etc. Parents don't want to know that their children know it. But in case there is a real taboo and there is a problem, you can still shift to fibrostimulation, ejaculation, and eventually, but this is more invasive, testicular biopsy. Of course, all these techniques then would be done under general anesthesia because otherwise it's not, of course, a solution. If we come to testicular biopsy, as you know, is also promoted for tissue cryopreservation, stem cell cryopreservation in prepubertal boys. There is a very nice paper that we published 5 years ago in the Human Reproduction issue, aiming that indeed it would become a routine protocol. In many countries is the case. In my country, in Belgium even, there is a reimbursement by the social security system for testicle biopsy in prepubertal boys. Of course, again, here the controversy or the unresolved issue is that we don't know which pathology, which cancer we should bank, and maybe which one we should not bank. And you see there are also non where stem cells, there is a risk for testicle degeneration in a lot of pathologies, and so some banks will indeed even bank testicle tissue in boys with the cryptorchid testis that undergo an orchidopexy, for example. Is this a good thing? I don't know. It's a big question mark. And especially there is a big question mark in banking already. Why? Because the banking part, yeah, we do it. But of course, the rest of the story, the transplantation or the in vitro maturation from the stem cells to mature sperm, this part is still experimental. It's still happening at the bench in labs, and there is no, at the moment, no success in the human. And so the best success are in fact, animal models, the rhesus model. But still we are doing it because we think it's good to start already banking to help these boys out maybe 10, 20 years from now. One thing that we stopped in Brussels in the meantime is banking in Klinefelter syndrome, because we don't think it's a good idea. Most of these boys don't have good stem cells, or very few have them. And the question, of course, is that those with stem cells, will they not become the adult ones that produce still sperm as Klinefelter patients? We really don't know, and we refrained from banking or promoting banking this type of patients. Okay, so maybe the wrap up, because my time is up, I think. So, okay, I think that I would promote the message that every man or adolescent, at least, who is facing a gonadotoxic treatment should have his reproductive insurance discussed at least, and I would promote it even. We should also make, let's say, a good awareness campaign, not only to patients, but especially to our colleagues. They should know, the oncologists, that indeed we do have good, efficient and effective preventive tools that double at least the chance to become a genetic father. They should also know that there is something more than only ejaculation. There is electroejaculation, there is testicle biopsy, there is oncothese. And of course, we should also maybe work towards policies, general health policies in every country, trying to improve access by awareness, make sure that the time spent to bank something is indeed minimal. Same for the distance and the cost, and we should probably try to set up networks, because most of us, we are working as single centers banking things, and maybe we should go to networks. And of course, as always, and we have heard this tonight several times, we certainly need more research, and especially to know what the genetic impact is in the human of chemotherapy, maybe just of cancer itself, and also, of course, the future of stem cell medicine. Again, there we need to do a lot of research to make it work. I thank you for your attention.
I have the pleasure to introduce Dr. Özgür Öktem, dear old friend and colleague. You know him very well. Let me introduce Dr. Öktem briefly. After his residency, he continued his academic career in USA, where he completed postdoctoral fellowship in reproductive endocrinology and infertility at the Center for Reproductive Medicine and Infertility of Weill Medical College of Cornell in New York between 2003 and 2005. Then he attended as a postdoc in the developmental and molecular cancer biology programs of the Memorial Sloan Kettering Cancer Center in New York between 2005 and 2008. He's a full-time professor of obstetrics and gynecology and assisted reproduction at the Koç University Hospital and School of Medicine. Dr. Öktem is also the founder and co-director of Reproductive Medicine Master of Science and Reproductive Medicine PhD programs in the Graduate School of Health Sciences at the Koç University, where he is mentoring Turkish and international students from different countries. He received many national and international awards. His clinical and research areas of interest include infertility, assisted reproduction techniques, preservation of fertility in cancer patients, molecular mechanisms of patients, of oocyte death, post-chemotherapy, corpus luteum biology, luteal phase defect, endoscopic surgery, menopause, and polycystic ovarian syndrome. It's a pleasure to introduce you, Dr. Öktem. The microphone is yours.
Thank you very much. Good night, everyone. I would like to thank again on behalf of myself and the board members of Turkish Society of Fertility Preservation to the invited speakers for accepting our invitation and joining our first international online symposium. Also, we are happy to announce that now more than 400 people from 45 different countries are now online to watch our online event. And I would like to thank again for the organizing committees and the sponsoring companies for supporting our symposium. I will be talking about the impact of radiation on uterine function. As we all know, cancer is the major global health public problem in the world. Every year, millions of people, young people, and pediatric age group are diagnosed with cancer and receive gonadotoxic chemotherapy and radiation therapies. As you see in this figure from National Statistical of United States, cancer incidence are on the rise in both sexes. However, their mortality rates are in a decline. So 5-year and 10-year survival rates of the cancer are increasing, and the quality of life issues have become more important than ever. Especially in the cancer in the children is another problem. And the most significant improvement has been obtained in the cancer treatment of the children with different kind of solid and hematologic malignancies. As we all know, the impact of cancer treatment on the female reproductive system is diverse. While chemotherapy drugs mainly affect the ovarian function, radiation impact both ovarian and the uterine function. Alkylating agents targets the ovaries and they cause massive follicular atresia. However, radiation impacts different compartments in the uterus in addition to ovary. Therefore, the impact of radiation on the female genital system are much greater than the chemotherapy. Now we have solid evidence that childhood cancers, especially if this data comes from the survivors of childhood cancers, they are more likely to have increased clinical infertility and the prolonged time to achieve pregnancy. And sadly, hormone replacement therapy doesn't reverse the uterine changes induced by radiation therapy. If pregnancy occurs, obstetrical complication increase in the survivors exposed to uterine radiation. And these effects, as you see here, uterine destruction of the different compartments in the uterine area, endometrium, myometrium, vascular structures, they cause infertility, miscarriages, preterm birth, low birth weight infants, abnormal placentation, fetal growth restriction, fetal malposition, stillbirth, and the neonatal death. There's two different mechanisms of radiation-induced cell damage and organ damage. One of them is the direct toxic effect of radiation on the genomic structure of the cells. And this radiation-induced particularly cause double-strand breaks in the DNA. And this will cause irreversible loss of vital hemostatic function of the cell and the eventual death, leading to organ dysfunction. The other mechanism, indirect cytotoxic effect of radiation that comes from its interaction with the other substance like cellular water. So we call this radiolysis of the cellular water, leads to formation of free oxygen radicals, and these emerging radicals reacts with different compartments in the cells, particularly the lipid layer, and cause lipid peroxidation and leading to organ dysfunction and eventual death of the cells. And this is particularly true for ionizing radiation like X-ray. Pediatric and adult patients exposed to uterine radiation for different reasons, for different radiation areas. One of them is pelvic radiation, like in the case of cervical cancer, bony pelvis tumors, or other form is craniospinal radiation for the cases of central nervous system tumors in the pediatric age group, or abdominal radiation for abdominal lymphoma or other solid tumors in the abdominal area, or total body irradiation before hematopoietic stem cell transplantation. If we look at in detail the mechanism of damage in the uterus, radiation cause impact myometrium, endometrium, and vascular structure separately. One of them is the most well-known effect of radiation on the vascular structures, which is radiation causes damage, sclerosis, and obliteration in the vascular structures in the myometrial and endometrial layers of the uterus, leading to decreased uterine blood flow. If pregnancy occurs somehow, this will potentially impair the invasion of cytotrophoblasts in the first trimester in the placental bed. And this will result in defective placentation, decreased fetal placental blood flow, and fetal growth restriction. Radiation-induced oxidative stress coming from the interaction of the free radicals with the different compartments in the organelles, in the lipids, in the membrane structures of the organelles and the cells. This will cause the activation of nuclear factor kappa B, and this will in turn recruit the inflammatory cytokines and the adhesion molecules, and will result in the formation of massive fibrosis. Initial injury is followed by inflammation of fibroblast recruitment and the conversion of fibroblasts to myofibroblast and finally extracellular matrix deposition and the fibrosis formation. Another compartment is the radiation-induced damage in the endometrial area. And this will cause the decidualization process and leads to a disorders of placental attachment like placenta accreta if pregnancy can be finally achieved. And the placenta accreta can be its clinical consequences can be very devastating. And we all know that endometrium has two different compartments. One of them is glandular structures and the other one is stroma. Radiation can induce damage in both compartments and may cause destruction in the basal progenital cell layer. If they are all wiped out, there will be no renewal of endometrial layer, and this will cause permanent endometrial atrophy, and it will prevent implantation process. During pregnancy, uterus will distend and will grow, and this largely is due to the elastic properties of the uterus. But if the uterus is exposed to radiation, especially in the myometrial layer, this will prevent the impaired endometrial uterine elasticity and will cause preterm labor and delivery. As you see in this figure, there's a study published in 2004 in ACTA. They compared the radiation with the control groups. Group 4 showed the direct uterine radiation, and the group 1 is the controls. And the group 2 and 3 before, below and after the uterine the radiation area below and upper part of the diaphragm. As you see, compare the control, there is a substantial decrease in the uterine volume in the patients exposed to uterine radiation compared to the controls. And these changes are unfortunately irreversible. When you look at the MR sections of these patients, you will see how endometrial thickness and the loss of junctional anatomy after radiation. Perhaps the most devastating clinical consequences are observed in the survivors who were treated with total body irradiation for mostly for hematopoietic stem cell transplantation, and the uterine radiation dose is more than 20 gray in these patients. Sadly, the most significant reduction in uterine size has been observed in this patient group. There is no uterine growth, no improvement in blood flow and endometrial thickness in response to exogenous sex hormone administration, an absence of uterine artery blood flow by Doppler ultrasonography, and significant increase in the first and second trimester losses. In addition, first and mid-trimester pregnancy losses, preterm births are significantly increased. Preterm delivery and overall risk of preterm birth was significantly increased when compared to expected incidence in the general population. There is a direct correlation between the dose of radiation and the risk of preterm birth. As you see in the odd ratio, there is a significant increase when you increase when the radiation dose increases more than 5 gray. Another important issue, the timing of uterine exposure of radiation to radiation. If the uterus is exposed to radiation before puberty, the effect of radiation is much more devastating. And the threshold value for the damage is much lower. While uterine radiation at doses more than 10 gray significantly increased risk of preterm birth, neonatal death after puberty. Group in Wilms tumor survivals. When females diagnosed with Wilms tumor were exposed to radiation, flank radiation, during treatment of their illness in their childhood, if they survive and reach the adulthood and become pregnant, their pregnancy has been complicated by hypertension, preterm labor and delivery, low birth weight, and fetal malposition. To sum up, the impact of radiation on the uterine structure is significant and the clinical consequences are really devastating, as you see in this figure, ranging from placenta accreta, fetal malposition, to intrauterine death. Uterine vasculature and growth potential during puberty can be permanently damaged by radiotherapy. So these effects can persist through lives into adulthood. The chance of pregnancy and full-term birth significantly reduced after uterine radiation. If the ovaries is in the radiation area or impacted by chemotherapy, we have other options like ovarian tissue freezing, oocyte and embryo freezing, but we don't have such a successful alternative in case of uterine radiation. Perhaps uterine transposition, uterine transplantation, and surrogacy can be a better solution for this group of patients. Thank you very much for your patience.
Is Professor Wallace, Hamish Wallace. The topic is fertility preservation options in pediatric cancer patients. Professor Wallace is a consultant in pediatric oncology at the Royal Hospital for Sick Children in Edinburgh and honorary professor at the University of Edinburgh. And his main research interests are infertility prediction and preservation for young cancer patients, Hodgkin lymphoma and mathematical modeling of biological systems. He's a co-author of more than 200 peer-reviewed publications and 4 books. He is the co-founder and organizer for ESLCCC, a biannual international conference on the late effects of the treatment of childhood cancer. He is consultant pediatric oncologist in Edinburgh since 1992 and honorary professor in the School of Clinical Sciences and Community Health at the University of Edinburgh. And the microphone is yours, Professor Wallace.
Good evening. Thank you very much indeed for that warm introduction. I hope you can all hear me quite clearly and see me too. It's I just wish that we all could have been together in beautiful Istanbul, but during these very challenging times, that's just clearly not possible. So I thank Professor Özgür Oktem for this kind invitation to join this online symposium. And a very special thanks to the organizers who have done a fantastic job bringing us all together, allowing us to meet in this virtual space and share our scientific ideas. So my brief is to talk about fertility preservation options in pediatric cancer patients. I have no conflicts of interest to disclose and no financial disclosures to make. As a pediatric oncologist, it's actually been a very exciting time. There is definitely a slow but steady increase in the incidence of childhood cancer. This is the SEER American data for all childhood cancers. And during that time, since the mid-70s, a very significant reduction in mortality. 5-year survival in the late 70s, about 62%. but from about 2011 onwards, 87%, and we're now approaching 5-year survival of over 90% of our children. So what does this survival actually hold for them? How can we visualize them? And this is a theoretical framework, which I think is quite helpful. This is the normal in blue, the normal general population who did not have childhood cancer. This is us. And as we get older, we acquire morbidity such that by the age of, let's say, 70, at least a quarter of us have significant morbidity. But what's happening with our childhood cancer survivor population, illustrated here, is that there is an advanced onset of morbidity, so that age for age they have more morbidity than the general population, and therefore an excess lifetime morbidity associated with cancer therapy. And when we see these patients in the clinic, and they now really do believe that they are going to be survivors, one of their major concerns is, can they have babies? Will those babies be normal? And of course, in most situations, their babies will be normal. And unless they have a genetic syndrome, their babies are not going to be at increased risk of cancer. But can they get pregnant? Can they have babies? And the whole field really came alive after this very important seminal publication from Jack Donnay and his group of a live birth after orthotopic transplantation of cryopreserved ovarian tissue, not in a pediatric patient, but in an adult woman. So this whole field really opened up with this publication of a live birth. And now, as you know, this was the publication that Donnay and Dolmans produced a year or so ago now with over 130, but we now have, we think about maybe 200 live births after reimplantation of ovarian tissue that has been cryopreserved and then thawed in an orthotopic site. So it's really very exciting times for us as pediatric oncologists to have this opportunity to preserve fertility in our young patients if they are at risk of premature ovarian insufficiency. But for girls, it requires an additional procedure, a laparoscopic usually procedure under general anesthetic. And as always, with our young vulnerable patients, we must first do no harm. So we must think carefully about which groups of patients we should offer this to. What can we offer? Well, we published this a few years ago, and during the course of this meeting, we've heard quite a lot about the different techniques that are available for patients with cancer. The first thing, I'll come back to that, is to make a risk assessment for all our patients with childhood cancer. I'll come back to that. For the men, as we've heard so eruditely from Herman, if they're post-pubertal, semen cryopreservation is established and should be offered. Testis tissue cryopreservation for the prepubertal patient remains very much experimental. I don't think anybody disagrees with that. And if we think about the girls, again, we have to define whether they're prepubertal or postpubertal. If they're postpubertal and there is time, they can undergo ovarian stimulation to oocyte cryopreserve, and we've heard lots about that. And if they have a partner, which is very unlikely in our age group, who can provide donor sperm, then embryo cryopreservation is also established. So embryo cryopreservation, oocyte cryopreservation for postpubertal females at high risk of infertility as a result of that. The treatment plan for their cancer is established. Ovarian tissue cryopreservation, certainly for the prepubertal patient, as we will illustrate as I go through the talk, remains experimental in my view. What is this risk assessment for fertility preservation? Well, we think about it in terms of intrinsic factors to the patient and extrinsic factors. So the extrinsic factors would be the nature of the predicted treatment. And as Herman's already said, that can be unpredictable and can change as the patient goes through their journey. But the nature of the predicted treatment is important, and I'll come back to that. The health status, are they well enough? Some of our young patients with stage 4 neuroblastoma are very sick at presentation. The patients themselves can't usually give consent, so therefore consent comes from the parent. Can we assess ovarian reserve? This is something that we would like to be able to do and remains very much an area of scientific study. Is the time available? In other words, do we have to start treatment? Have they got a mediastinal mass? Are they having difficulty with breathing? Do we need to start treatment immediately? And of course, is there expertise available? And that includes not just the surgeon to take the laparoscopic tissue from a prepubertal girl, but also the storage facilities and the whole team to cryopreserve the tissue. We've heard a little bit during this symposium about the risk of infertility. What I wanted to say here, yes, low risk, medium risk, high risk, we have to try to classify our patients. And we're all pretty much agreed about who is high risk. If you're going to get total body irradiation as part of the conditioning treatment for a bone marrow transplant, then you are at high risk of not having the opportunity of fertility in the future. Direct radiotherapy to the pelvis, testes, chemotherapy treatment as conditioning before bone marrow transplant, and treatment for metastatic Ewing's, pelvic radiotherapy as part of Hodgkin's lymphoma treatment. But you can see that Hodgkin's lymphoma treatment features not just in high risk, but medium risk and low risk, because it depends on the nature of the treatment. It's not the diagnosis that determines the risk of fertility, it's the planned treatment. And that can so often be difficult to actually determine at the outset. So I wanted to talk a little bit about whether there was a role for the oncologist in preserving fertility. We've heard a lot about the different techniques and their success rate, but what about a role for the actual oncologists themselves in preserving fertility? Well, I think there's two ways that we can think about this. First of all, we can remove gonadotoxic chemotherapy where possible, and I'm going to give you an example of where we've done that in the treatment of classic Hodgkin lymphoma in young people. Then I'm going to talk about decreasing radiation exposure to organs at risk, particularly the ovaries and uterus, which we're very interested in this symposium. So are there new ways of delivering radiotherapy? Do protons versus photons? Protons is the new treatment, photons is the old X-ray treatment. Is there an advantage to try to deliver radiotherapy using protons, which is very expensive, and decrease the exposure to organs at risk, particularly organs like the ovaries? So let's think about the chemotherapy question first. And this is a study that I was a major part of. It's been a major part of my life. It's called URANET, Pediatric Hodgkin's Lymphoma, Classical 1. We give intensive induction chemotherapy. There were two aims to this study: a response assessment using PET scans. And basically, if you had a good response to 2 months early induction chemotherapy and you were PET negative, you didn't get radiotherapy. So no radiotherapy exposure. If you were PET positive after 2 cycles of chemotherapy, then irrespective of whether you were an early TG1, intermediate, or advanced stage disease patient, you got radiotherapy. So that was the radiotherapy question. But what's really interesting here is there was a randomized question. A randomized question to see whether this drug, beginning with P, called procarbazine, which was standard treatment for Hodgkin's lymphoma, could be replaced successfully by dacarbazine, an effective treatment in Hodgkin's, part of the ABVD regimen, but perhaps, and we needed to prove this, less gonadotoxic. So patients with intermediate and advanced stage disease who needed 2 or 4 cycles of chemotherapy more to cure them, with or without radiotherapy, depending on their response assessment, were randomized to remove a gonadotoxic drug. Is it safe to do so? And is there less gonadotoxicity with dacarbazine? So overall, we're now able to report the results of this study. Overall survival, shown in green here, was fantastic. We had over 2,000 patients, only 19 deaths, and 98.7% overall survival. Event-free survival and progression-free survival were just under the 90% mark. So the results were very, very good, very satisfactory. Most of the patients that relapsed or progressed could still be cured. So this is a very curable cancer. Therefore, fertility preservation, whatever means we can use, is important. So for the intermediate and advanced stage patients, was it okay to remove procarbazine and give them dacarbazine instead? And you can see here from the event-free survival graph that they're overlapping. There's no significant difference. So quite clearly, it's safe to replace procarbazine in COP with dacarbazine. It's just as good at curing our patients. So is dacarbazine less gonadotoxic than procarbazine? It's certainly as efficacious. So this is a study that actually has some really good fertility data. This is FSH in males at follow-up. This is an empirical distribution function. In green, we've got patients that just had the 2 cycles of induction chemotherapy. In blue, we've got patients who had 2 cycles of induction and were exposed to COPDAC, the dacarbazine-containing regimen. And in red, we've got the patients who had 2 cycles of induction and then 2 or 4 cycles of the procarbazine-containing regimen. We know procarbazine is gonadotoxic, and this is confirmed here. Here we have about 50% of patients at follow-up with an FSH over 12, indicative of damage to spermatogenesis in those patients. But the patients that were not exposed to procarbazine, those patients that received dacarbazine, do not have an elevated FSH, suggesting no indirect damage to spermatogenesis. And when we look at semen analysis at follow-up, and we have quite a lot of data, 53 semen analysis, we look at the incidence of azoospermia after OAPA alone, none, after COPDAC alone, none, but 19 out of 23 patients exposed to procarbazine were azoospermic. But that's not the exciting thing. This is what's exciting. There were no azoospermic patients out of 22 patients exposed to OAPA and COPDAC. So not only is COPDAC as efficacious as COP with procarbazine, actually it's much less gonadotoxic in our study, in our randomized study. So that's one way the oncologist can contribute. We can remove, if we can, in a proper scientific way, drugs that we know are gonadotoxic. What about the radiotherapy question? And this is also very interesting. We don't need to know much about radiotherapy, but we do need to understand something called the Bragg peak effect. It's actually very easy. Here we have conventional radiotherapy, X-rays called photons, and here we have the new radiotherapy, protons. What is the difference? So this is the depth into the body. So here's our tumor lying at 30 centimeters beneath the surface of the body. X-rays get in, deliver their energy where you don't want it, in the first 10, 20 odd centimeters, and then they also deliver it on the way out as well. So there's damage occurring to surrounding tissue before the tumor and after the tumor. The amazing thing about protons is that they deposit their energy with maximum effect to the depth where you want the tumor, where you want it. So you decrease the damage to surrounding tissue. So we know, and we've talked about this before, that the human oocyte is exquisitely sensitive to radiotherapy, and that we will kill 50% or more of our primordial follicles with a dose of 2 gray or more. The LD50 is less than 2 gray. So that's really quite a small dose to kill 50% of the surviving follicles. How does that translate into practice? Well, let's take a patient of 15, a young girl treated at the age of 15, and let's measure the dose that is received by the ovary furthest away from the radiation field. And in green here, it's 6 gray. So that's a very small dose. 6 gray to the radiation of radiation to the ovary furthest away from the radiation field. And we can see that by our understanding of the radiosensitivity of the human oocyte, she is going to develop premature ovarian insufficiency at the age of 30, 32. So that means she's going to be subfertile for the 10 years before that. And that means actually that she's probably not going to have a window of opportunity for fertility with such a small dose. So we need to get the dose to the ovary furthest away from the radiation field down to improve her chances of having a reproductive window. So this is proton therapy, and it's really very interesting. This is a conventional plan for an 8-year-old patient with a pinealoblastoma. So they've got a very nasty tumor in the center of their brain here. And the conventional treatment is to deliver a high dose to the pineal region. This is photon plan, the X-ray plan, and craniospinal radiotherapy to the whole of the craniospinal axis. And what we're showing here is with conventional radiotherapy, photon radiotherapy, versus the proton plan, where there is less damage to the exit site tissues. You can see this here on the cross section. A large dose is still being delivered to the anterior structures where we don't want it, where the energy is being deposited where we do want it, to the spine. So we can estimate that premature ovarian insufficiency will occur at the age of 14 with photon radiotherapy because of this high exposure. The ovaries after photons are getting a maximum dose of 10.8 gray, as opposed to with the proton plan a maximum dose of 2.45, and the median dose the mean dose significantly reduced. So no change in the dose to the tumor or craniospinal axis, so same chance of being cured, but decreased exposure to organs at risk. And we've heard how important that is from Professor Oktem's talk in terms of the uterus, and in terms of the ovary, it's vital, as I've just shown. So fertility preservation for prepubertal girls, because they have lots of immature follicles, is potentially very attractive. Will prepubertal ovarian tissue restore endocrine function? And will prepubertal ovarian tissue restore fertility? Well, we know something about endocrine function. This is a very important study from Klaus Anderson's group about induction of puberty by autograft of cryopreserved ovarian tissue in a 9-year-old who had Ewing sarcoma. She was treated intensively with chemotherapy and radiotherapy and had ovarian tissue cryopreservation before treatment commenced. She developed premature ovarian insufficiency, had no pubertal development, and was in remission. 4.5 years later, at the age of 13.5, ovarian tissue was thawed and returned for pubertal induction. She achieved Tanner breast stage 4, almost adult breast development, and menstruation really very quickly within 1 year. But the graft ceased to function after 19 months. So she definitely got endocrine function when the tissue was replaced for pubertal induction. But very sadly, several years later, she relapsed and died from recurrent Ewing sarcoma. However, there was no evidence of the molecular signature for Ewing's, the EWS-FLY1 gene, in the remaining stored ovarian tissue. So we don't think that the recurrence of her Ewing sarcoma was caused by the replacement of the tissue. So that is evidence that induction of puberty can be successfully done by transplanting the tissue back in. But induction of puberty with exogenous steroid hormones, either orally or transdermally, is well established in practice in Turner syndrome. The reimplantation of ovarian tissue in a hypergonadotrophic environment with high gonadotropes, I don't think is ideal, because the patient goes through puberty at a faster rate than they normally would. And by putting this very important tissue back, it is a potential waste of a finite number of germ cells that might be important for that patient in terms of fertility later on. There is a risk of relapse, particularly in hematological malignancies, and we've heard about that from Mary-Madeleine. So although there is proof that we can induce puberty and get endocrine function that from tissue that is harvested prepubertally, we don't have a lot of evidence until quite recently, also from Klaus Anderson, of a successful pregnancy in a woman previously suffering from beta thalassemia following transplantation of ovarian tissue cryopreserved before puberty. To my knowledge, there are no pregnancies in women following transplantation of ovarian tissue cryopreserved before puberty who had a cancer diagnosis, but this is a patient who had thalassemia. Great story. The patient came from the United Arab Emirates, suffered from thalassemia, had ovarian tissue frozen, in fact, in Leeds in 2001 when she was aged 9, so entirely prepubertal. She had a bone marrow transplantation for her thalassemia, which was successful. The tissue was brought to Denmark in 2015 and transplanted back into that patient. Many years later, that's 14 years after it was frozen, and the patient conceived after IVF treatment in London in the UK under the guidance of Sarah Matthews and gave birth in December 2016. So this is the first real proof that we have that this prepubertally harvested frozen thawed tissue, when returned, can actually cause a live birth. Not the cancer patient, but the patient with thalassemia. So recently, we have been working hard on recommendations for fertility preservation for male and female childhood, adolescent, and young adult cancer patients. And we now have 2 publications in press with the Lancet Oncology. Now, this is an evidence-based clinical practice guideline. the grade methodology was used to grade the evidence and recommendations. And it was a multidisciplinary, worldwide collaboration. The PanCare Life Consortium, in collaboration with the International Late Effects of Childhood Cancer Guideline Harmonization Group, using grade methodology to produce recommendations based on the evidence for fertility preservation. So this is what will be published very shortly. It's in press now. This is for female childhood, adolescent and young adult cancer patients diagnosed before the age of 25 years. In green are strong recommendations. In yellow are moderate recommendations. Where there is evidence that it should not be recommended, that is in red, and when there is insufficient evidence for no recommendation, that's in white. So a strong recommendation that all childhood, adolescent and young adult cancer patients and their parents, caregivers, partners, who are at risk of infertility for cancer treatment should have counselling. Okay, they should really have counselling. Very important, even if you're not going to do anything. There is a strong recommendation for post-pubertal patients. So here they're divided into really very high-risk group who's going to have direct radiotherapy to their ovaries, high-dose stem cell transplants, a bone marrow transplant, or very high-dose alkylating agent chemotherapy, as opposed to low-dose alkylating agent-based chemotherapy and cranial radiation, and as opposed to unilateral oophorectomy. A strong recommendation for oocyte or embryo cryopreservation in the post-pubertal patient in that very high-risk group. Moderate recommendations for prepubertal and post-pubertal for ovarian tissue harvesting based on the evidence. Based on the evidence, we came up with a moderate recommendation using grade. And oophorectomy before radiotherapy to the ovaries, if the ovaries can be moved out of the radiation field, a moderate recommendation based on the evidence as published so far. Not recommended, of course, to take ovarian tissue from those patients who are going to get not high-dose chemotherapy and just perhaps cranial radiotherapy as part of treatment for a brain tumor. So really, this is really very interesting evidence to try to tell which patients are at highest risk based on the evidence. We need more evidence, certainly. The ongoing challenges include providing fertility counselling to all young patients with cancer. That is a must. Our young patients must have the opportunity to be exposed to counselling. We must cryopreserve ovarian tissue from the right high-risk patients. We still need to define the success rate of the procedures for children as well as adults. And as Evelyn Telfer was saying yesterday, develop in vitro growth and maturation as a safe alternative through basic research. So you don't have to put the tissue back, don't expose the patient to recrudescence of the original disease. So thank you for your attention. I want to highlight my collaborators. A lot of this came from David Baird and Roger Gosden's early work, as you heard from Richard Anderson yesterday. Richard Anderson, great friend and great collaborator. Tom Kelsey, a collaborator of mine from St Andrews University, and with the mathematical modelling studies, our endocrine team, our surgeons. Thank you very much for your attention. Thank you.
Thank you indeed, Professor Wallace. I really enjoyed this session as a radiation oncologist. We have many questions, but the time is limited. Let me ask the first question to Professor Tornay. As you know, there are many patients who didn't have the opportunity to have the initial assessment for fertility preservation before their treatment. And let's say a young gentleman, 27 years old, received chemotherapy and radiation is to abdomen to para-aortic area. What's the safe duration for, or the optimal duration for the conception, either assisted or naturally?
Well, most publications will say that it's best to wait for 2 years, because as I showed you, I didn't mention it on the slide, the increased risk for congenital malformation in the offspring is up to 2 years, and afterwards it goes down. So you could say 2 years. If then still there is an azoospermia, then we would proceed to a testicular biopsy, trying to recover some sperm, which probably may work out in a little bit less than half of the patients.
Thank you very much. And
Dr. Wallace, we have a question for you. Can we interpret AMH results in pediatric patient population as we do in adult population to assess the ovarian reserve? This is the question.
A question to me, sorry. Yeah. So this is a very important question and a good question. As you know, we know quite a lot about, we know that AMH is produced in young patients. We know that it peaks probably around about the age of 23, 24. We know that it then declines towards the menopause. And during that period, between about 23 and 40 to 50, it's a very good indirect measure of ovarian reserve. But the journey from conception through to 23, 24 is a difficult one to understand because there are two peaks. So AMH is rising, I think, telling us something about the ovarian activity that is going on even before menarche, but we don't yet know how that relates to an accurate assessment of ovarian reserve in our young patients. So more research is required there for us to be able to interpret an AMH level in a young female patient as an indirect measure of ovarian reserve, in my view.
Thank you. Actually, thank you all for these fantastic presentations and this wonderful session. And dear colleagues, thank you for being with us in this session. We'll be expecting to see you tomorrow to continue with the sessions, and especially the fertility preservation course to be continued on tomorrow.
Thank you.
Thank you all.
Thank you. Good night.
Thank you to the organizers. Good job.